helped us to go along and realize that indeed, for us to move forward, we need information at our fingertips. And this, I want to encourage you, my brother. You should encourage our team, especially at the lower health facility, to keep data. Because we do a lot of things in our respective area of work, but we don't profile them. Because now you are seeing your area of studies, those who have got publications, because of your simple directions and say, get for us this information. When indeed the informations are lying at our facilities and we don't know how to use them. But when you bring it out, it will help you to know the numbers of people you have who always attend with different cases who come to a facility. I think, colleagues, let's take this very serious. Let's take it very serious, more especially biostatisticians. We need to take it very serious and improve on this. I have been encouraging my team about removing rates in the database of Ministry of Health. They will want this data is not there. But you go to a health facility, you will find out there are a lot of things like records of death. Because by law, these are supposed to be accounted for. But you realize that it happens in our facility, but it's not recorded anywhere. I have now realized that you can acquire the doctoral papers just while sitting from his presentation. Well, me now you have finished me, so wait. You have finished me today. Now I've seen. So, Oriakun, my brother, we are now there. Don't worry. You have opened. So I was suffering, moving the whole continent. Just for studies. So you can get this thing around and you're done. My brother, what do? I can now see Dr. Osborne in the next. That's encouraging.
Yeah, thank you. Thank you, Doctor. I'm also sorry that I came my phone in the middle, but there are things that caught my eye about issues of missing data, missing historical inconsistent something, which I think can be done if we have like a uniform document where each person can follow. And therefore, you also talked about national health data, having national health data. So with your experience, what does it take to have this national health data, which is the same, so that if I crack a patient in Lira, it would have the same information like somebody clacking from Gulu? What does it take to have that? Thank you.
Special announcement. The team that went to Lylon bring sugar, I will be released. And immediately after Dr. Bomah making a few remarks, we shall switch off to our tea. And after the tea, we shall have Dr. Bomah take on with his team. Thank you.
Yes, thank you so much, Prof. Prof. Tim Tom, our teacher. I'm sure that Pijumide remembers him very well for pulling the manu. For pulling the manu. Yeah, so of course, you know, like we all have this standardized way. I think the most important part of that answer, by the way, is attitude. Yeah, because we all know when you're tracking a patient, there's demographic, presenting complaint, history of presenting complaint, past medical, past surgical, guide, social history, review of other system. You understand? All this data is at the back of our mind. But then for us, we just chose to say 34-year-old female, polycystic ovarian syndrome, treatment. I know polycystic ovarian syndrome has a new name. Prof. Rogers will be you guys, what are you talking about? Yeah, PMOS, yeah. So I think it is attitude. And also we don't have good quality improvement projects and guidelines for us, because I mean, when you're practicing in the UK, I mean, or any other high-income country, you need to adhere to the guidelines to the dot. Yeah, to the dot. If the system EFIA states there's provision for presenting complaint, there's provision for history of presenting complaint, there's provision for physical examination, and for all that, and then for you, you don't put in those details, then you know you are not adhering to institutional guidelines or national guidelines, and then you know your license can be revoked. So I think for us, one, we have very poor adherence to guidelines, and then number two, we don't have the attitude or the correct attitude towards completion. Or we say I don't have time for all that. You understand? Because after all, my boss, professor in the UK, sits up to 9 p.m., you know, dictating clinical notes into the system so that every patient's detail is up to date. But I mean, even as MO doesn't want to touch the file, it's dictating to the intern to write, and then doesn't even view what the intern has written. You understand? So all those level of flaws impairs the quality of data that finally get captured at the national level. So until when we change our attitude at all levels, from pre-service to initial service to seniority, the seniors have to be exemplary, not just by dictating notes to the juniors. Thank you.
Thank you. Thank you, Dr. Bomah. I think with that, you earn yourself a cup of coffee.
Okay. I see Rachel, Dr. Nathan.
I told somebody came from Olailo. Dr. Menk.
Thank you, Dr. Bomah, for that very good presentation. I think what we could do, if you could get time and talk to the health workers, lower level health workers. Surely we have a lot of data which we don't use. I realized this when in 1991, when I went for my master's. In 1991, I went to biostatistics. I didn't do biostatistics. And this is what we are talking about. It is reminding me exactly what we went through. And it is very important. You find this in a lot of data which is scattered all over the place. We don't analyze it, we don't use it for making decisions to improve our health performances and so on. For example, yesterday, Raymond gave us a lot of data. The population of actually region is about 2 million? That's our population. The number of health facilities is 350. I was looking at them this morning. That's from here, about 350. Now, this one alone can help you to calculate accessing. Now, if you take it at district, you will know which district is well supported infrastructure and so on. You can look at the number of health workers. Say in Gulu Hospital, at least I'm aware of that. You find a whole regional referral hospital. Do you have people from Ministry of Health? The whole regional referral hospital has a staffing level of 30%. And of the 98, 99 consultants, senior doctors needed, they are less than, they're about 11. You can look at that. These are the figures you can analyze. When the guest of honor is the Ministry of Health, if you don't want to talk, I'll talk to him. and tell him this is not acceptable. But we looked at antenatal clinic and antenatal services yesterday. Gulu City is doing very well. Gulu district is the worst. What does it imply? We go to Gulu district and look what are the facilities there. Having been an old man here before, I know mine as Gulu municipality, Gulu district is Aswa, is it? Yeah, Aswa is when it's not, there are very few hospitals. And the health center for is probably. So those are some of the things these decisions can be made at a lower level. When I came back, that's what I applied for decision making, for planning, and so on. And when you are young, you used to hear that Gulu district is number one. It is just using available data and convincing the politicians and the health workers to change their way of thinking and implementation. Thank you.
Thank you so much, Dr. Nek. Thank you, Dr. Nek. And the last one is here.
Thank you so much, Dr. Bomah, for the wonderful presentation. When you look at your research areas, all in health, and looking at that in health, when you come down, you look at the population of the healthcare workers, the majority are the nurses and the midwives. And when you look at your research area, you have underutilized midwives and nurses. So how best would you help this? If you underutilize the largest population, sometimes we may not get the best for our region. And I don't know whether you would look at this pre-publication class to support the region as well, people coming into the world of research. Thank you.
Thank you so much, Rachel. Number one, if I agree to that, then PEPAL will slap me, because through 28 seed grants that we gave to people, me and PEPAL and the SAT project, many of them are midwives. Jack is there, and Ariel, all they are midwives, yeah? Each of them were principal investigators. They did their job, and all of them got published as well. Yeah. So if you had said my research interest is fungal disease, infectious disease, I would agree. Yeah. Which actually mostly have given up on it. Now I only do 40% fungal infectious disease. Now 60% is everything, because I want my overall aim, by the way, is to support people, as you will see. So you will see that my research line changed from 100% fungal disease up to 2018 to now anything public health. And that was why I did MPH, to help people. That's it. Yeah, and so that people do more. And that is what I discovered. That is what I discovered as well. I do more when I work with more people who can then do more of the work. So then I increased from probably in 2020, I had like 18 publications, 2021, 64. Then after that, all in 50s. Every year, I publish 50 papers. Yeah, that means every week. Even yesterday, even next week, it will come. Yeah, every week, the paper has to come out. It's through working with people.
Okay, I think, can we pick this one? This one will lead us into coffee. Well, I think the last year to coffee, and then we'll have Eric, the Assistant Secretary, to lead us in a word of prayer, and we'll go for our coffee. Welcome.
Dr. Bomah, been very impressed by the great work you're doing here. We hear it from where we see it from where we sit, and you make all of us proud. I believe some people might be wondering, how do you manage to balance? I suspect you do some clinical work, there are social engagements, you teach, and you're also highly productive in research. So how do you manage to strike a balance? And what is the trick?
So, thank you. I am very happy to see you stand in front of us and make all these presentation achievements. But we can still do more together. There is this saying of quantity versus quality. And in research, it is very important that what you produce and publish should lead to a very big change. It should be something that can change something. So over these 200 publications, how many of those ones do you prioritize that has caused a change? This is the way I want you to think and moving forward to the field of research. Thank you.
Yeah. Thank you. Yeah. So, I mean, sometimes people ask me those questions. I have published in all the big journals of the world, from New England Journal of Medicine, the Lancet, Clinical Infectious Disease, Nature. Like, think about it. Any top medical journal I've published, and not just one. So, I mean, if Lancet, I have maybe 8 Lancet papers, New England Journal of Medicine. So, I mean, as far as quality is concerned, it's not a big problem. Reach the climax of quality. And I've only not done one study design, which is a double-blind randomized clinical trial. That is the only study I've not done, and the only article type I've not published, but I've published all. And then, of course, I work with people. I've changed WHO guidelines. I sit on the WHO guideline for everything fungal, for everything essential diagnostic list. This thing of saying cryptococcal antigen test should be done in advanced HIV disease is my work, 2018. That toxoplasma should be screened. That urine lung should be added for everyone with CD4 less than 200. That is my work. I was the first author of that paper. And then, of course, I've shown you my WHO guideline. I lead the WHO, the world guideline for cryptococcus, for aspergillus, for candida as well, and the same as fungal asthma, which were published in leading journals in respiratory medicine. So we have changed. All that, sometimes I don't have to shine. The rule of the game, never outshine the master. So usually me, I stay, like Rogers, I say, most time I do more music stuff than showing off. That I'm a big guy. And that is what I told Bomah as well. Don't read all my profile. Yeah? That you shouldn't read all. But I mean, I have over 460 publications, not just 200. And then, of course, Rogers, it is the same story. So Rogers is the fastest person to get a PhD and become a professor. So sometimes people's lives will be different. People's pathways will be different. And then, we can always balance what we can do, but most importantly, do what needs to be done. I still see patients 3 days a week in private and public practice. Dr. Pascal is actually my boss when I'm working in Gulu Regional Referral Hospital. I still teach. I'm teaching Gulu University Medical School, obviously. But I think my biggest power, which Dr. Alarapolde will tell you, is that I've worked with over 2,000 investigators in every country, in every continent of this world. Yeah, 2,000 plus are the number of people I've worked with. And I can reassure you, 60% I've never met them in person. That is the interesting part. Yeah? So sometimes, and that is what Dr. Bomah was asking me, what is the importance of putting your profile on the university webpage? Because people will know. When you type that, who is the best person I can collaborate with on fungal disease in Africa? So my name has to be either 1 or number 2. Then people will get to me. You understand? Okay.
I think, doctor, as you walk in a majestic manner, you wait and lead us, since you're a lead us into a coffee cup. Please, Eric, as you said, this prayer, make sure that doctors, the footmarks and footsteps are followed by many. Can you stand up and have a prayer for our team?
Heavenly Father, we thank you for this day. We thank you for the breakfast. We pray that you bless the breakfast that we're about to get so that we can effectively utilize this conference in Jesus' mighty name. Amen.
Thank you. Dr. Bongamin is leading us for tea. Let us follow him. It's coffee. Thank you so much. Remember, we're using 30 minutes. Dr. Bomah, get set. The next stage is yours. Enjoy the tea.
Hi, big women in the house. Which one? You can see this special. This one is my.
No, not that. What is doing? That is what. But you mean by three, see, I'm so happy. I very much. Read that to the other. Yeah. Right. Yeah. Serious signature. People like this.
Come with a cup of tea, don't worry, it's in our space. If you have had more, you can say, have a gathering back. Please come in. Union is concerned that she wants to take on the programming, but people are coming slowly. Those are out, come in. Gideon is ready for us. You must say what or not here, but that's my local content here. Those are from outside. I want to invite Gideon to take on the recognitions, and we shall see how to break them down. And those that shall give other branches of recognition. And if possible, we invite 1 or 2 people to do some recognitions. Gideon, can you let us know who is in the house? We'll go with the newest, those who have just come in.
All right, good morning, team. Hello. Good morning.
Good morning.
Yeah, you're most welcome for our day 2 engagement. And I'm very excited that today we have been joined by very powerful people. And we're here to learn from them as they also learn from us. So we are going to, first of all, thank God for being here today with a very good hand clap. Thank you. So in a special way, colleagues, today we have been joined by senior colleagues who are in practice and in various areas of engagement. And we have Dr. Okello Patrick, the radiologist. Doctor, you're most welcome. You can just wave to the house. Dr. Patrick Okello. Okay, maybe I stepped out a bit. All right. On the other note, also today we have been joined by Mr. Ndugu Robert, who is the DCB CTO in the house. Thank you so much. You're most welcome. And colleagues, today we have also been joined by Mr. Onen Herbert, a medical clinical officer. You're most welcome, Herbert. We appreciate your presence. And colleagues, our senior lecturers are also still with us. We have Dr. Pebalo, who was actually giving us very important knowledge about the head circumference. And today again, he's still here to continue giving us more knowledge as he also learns from us. Dr. Pebalo, thank you so much for sacrificing your time. You're most welcome today too.
You added Pebalo.
Pebalo. Thank you. And colleagues, in the house, we also have the chair for this very important event, who has also sacrificed a lot, right from thinking about what should this be like, how should it be, how should it go, and that is Dr. Jimmy Ope, the last born of the university, with a very bright brain. Doctor, thank you so much for your sacrifices. In this house, you're the first born for the conference. Thank you. And colleagues, also in a special way, we have been joined by the multimedia journalist who is also capturing every event that is taking place here. And that is Mr. Margaret David, who is from the Vision Group. Sir, you're most welcome to interact with us and our team members. Wherever you are, you can just wave. Mr. David Margaret from the Vision Group. All right, maybe he's, oh yeah, he's there. Thank you so much, you're most welcome. Colleagues also in the house, we have an obstetrician and gynecologist who has also been acting as the chair of the scientific committee for this conference, and that is Dr. Bomah Stephen. Doctor, thank you so much for the sacrifices and being here with us. Thank you so much. Colleagues in this house, we are very gender sensitive. We do not have only men. We also have ladies of virtues who have sacrificed and are doing a lot of great things for us. In a special way, allow me to recognize Miss Miss Sharifa, the epidemiologist. You're most welcome, Sharifa. Thank you for joining us today again. You can just wave to the room, wherever you are. And probably she also stepped out, it's okay. And colleague, we have also been joined by Miss Napadansi Winifred, a senior orthopedic officer. You're most welcome, and thank you so much for coming to learn with us. And colleagues, we also have a senior lady who has also played a very great role for having us in this gathering today. That is Mrs. Onewun Gloria. You're welcome, Gloria, to just wave to us. She's the Deputy Director of Bomah Foundation and also serves as the REC committee member, a community representative. Thank you so much. Thank you for joining us. Then we also have Ms. Agnes Laniero Patricia. She's the REC administrator. And if you see her seated here today, she has been doing a very great role. She's right there behind us. Thank you so much, Agnes. Really appreciate all the efforts. Then, colleagues, today we have also been joined by Susan Akelo, a nursing officer. You're most welcome, Susan. Really appreciate your sacrifice and urge to learn. Colleagues, in this house, we also have very serious students who have also sacrificed to come and learn. We have Ms. Christine, a medical student. You're most welcome. We really recognize and appreciate your time with us. Then we also have an associate coordinator, cardiac clinic, who is representing the Heart Institute, Ms. Susan Akulu. You're most welcome to join us. You can just wave to the house. And in a very special way, we also have Ms. Akulu Dina, an enrolled midwife who has also joined us today. Dina, you're most welcome to learn with us. Thank you so much, colleagues. And for us who have been here yesterday, thank you so much for really having the heart and coming back again. We love you all and we say we're here to learn so that we go back and serve. And next year when we come back, we shall be seeing something better and great from all of us.
And of course, it can't get concluded without recognizing and also mentioning the event managers. For those who are not here yesterday, your event managers will have Mr. Obiakun Walter, it's standing here. And next to Mr. Obiakun Walter is
Miss Gillian J. Sapio. Thank you.
Okay, I was afraid I thought you said Mr. Obiakun Walter. That's the job. Ladies and gentlemen, permit us to welcome Dr. Bagu, the specialist.
And as Dr. Baguma steps in, we also have new delegates who have joined us today from the Association of Medical Practitioners, and in a special way, Dr. Baguma is going to recognize and welcome them ministers. Thank you.
Thank you very much. Our MCs, thanks for the wonderful work done. In a special way, allow me to recognize the presence of the president of the Association of Obstetricians and Gynecologists of Uganda, Professor Kajawangu Rogers, is in our midst. Members can clap to him. It's a huge sacrifice for us to have him here, and we are really appreciative and we're very glad. Also, allow me to recognize the presence of Associate Consultant Charles Irumba. He's an obstetrician and gynecologist, and also a gynecologist at Women's Hospital in Mulago. He also bears the chair of the Deputy Secretary General of the Uganda Medical Association. Welcome, you're very welcome. Dr. Charles and Dr. Rogers. Yeah, thank you very much. So at this juncture, allow me call up the next presenters. We're going to have some presentations of research that's been done within the region by some of our colleagues here. Susan Mwai, you may please come up. Christine Nanunji, please come up. Dr. Byron Awekonmungu. I don't know whether Irene Omono is around. Is Irene around? She's going to present online.
Yes, Irene is going to present online.
Oh, thank you very much. And Aban Chihumoro. Yeah, you can take your seats. These are going to be our presenters today, and they're going to be sharing with us abstracts of research they've done within the region in areas of maternal child health and also other health indicators. Thank you very much. So we're beginning with Dr. Byron Awekonmungu. Just a brief bio about Dr. Byron. As he comes up, Dr. Byron Awekonmungu is an intern doctor at Gulu Regional Referral Hospital, and he's also a researcher experienced in health system strengthening, especially in the West Nile region, with over 10 years of experience in the areas of quality improvement, integrated disease surveillance and response. He holds a bachelor's degree in medicine and surgery from Gulu University, and a postgraduate diploma in project planning and management from the International University of Islamic University in Uganda, a postgraduate diploma in monitoring and evaluation from Gulu University, and is currently a final year student pursuing a Master of Public Health at AOGU, and is also an MBS scholar. Ladies and gentlemen, Byron Awekonmungu.
So, my work is in Gulu Regional Referral. With some colleagues was when I was doing my undergraduate at Gulu University for my MBCHP. We were able to look at a few things, especially towards ultrasound utilization. A few of our senior lecturers here helped me in supervising me. Dr. Bomah Felix, Dr. Pe, Jimmy were able to help me. So I'll be looking at the factors influencing utilization of antenatal ultrasound scan in a tertiary facility. That is Gulu Regional Referral. Yeah, we can go to the. Okay, so like I told you, we are looking at factors influencing utilization of antenatal ultrasound scan in Gulu Regional Referral Hospital. We were able to do this work with a few of my colleagues, and luckily enough, one of them is there, Nanunji Christine, who happened to be one of the people I worked with. So in my study background is that WHO recommends that at least you should have one ultrasound scan before 4 weeks. That is the recommended, and this helps in detecting fetal anomalies, estimating the gestational age. It also, at the end of it, when you are able to detect fetal anomalies early, it helps you to improve the pregnancy outcome. Now, the national utilization of ultrasound remains low. So we wanted to know what is it
to disaggregate it further to Gulu Regional Referral and see how it works within here. Go to the next slide. So nationally, right now it stands at about 30% national ultrasound utilization. And because it is being utilized at a very low pace, it helps, it actually makes it late for us to detect complications which occur. That is why babies with abnormalities are born without even sometimes being detected. Sometimes on table, you are doing a cesarean section, that's when you detect it. Or a mother gives birth, that is when you will detect that this baby has a lot of congenital anomalies. So there is increased maternal and perinatal risk, and there is limited data in the northern region. So it prompted us to get to know what is the utilization rate. We tailored it that maybe if we could get data on Gulu Regional Referral, which is the tertiary facility in Acholi sub-region, it could point a picture of how the utilization is in Acholi sub-region. So our objective was to assess utilization of antenatal ultrasound scans at Gulu Regional Referral, but specifically wanted to determine the prevalence of antenatal ultrasound scan utilization. And then we identify the factors. What are the factors associated with this utilization? So in our study setting, in our design, we did a snapshot, a facility-based cross-sectional study. That was the time that we were doing it. And it was in the Gulu Regional Referral Hospital ANC clinic after obtaining ethical permission from GRRH and also Gulu Regional Referral Rec. That's when we were able to go and collect data. The period was from November 2023 to March 2024. We used Kish and Leslie to try and calculate the sample size, and we came up with the sample size of 374. And then we randomly selected them, pregnant women. So we used an interviewer-administered questionnaire to try and collect this data. You can go back a bit. And finally, data was analyzed, and we looked at every p-value below 0.05 as significant. So in the median, these were the participant characteristics that we sampled. The median age was 26 years. We found out that about 66 aged 20 to 30. 66 came to about 247 mothers. And then 75 of these mothers were coming from within the municipality. That is, they were from the urban setting. That is about 281. It translates to about 281. 88.5% were married. These were about 331. 66.3 were multi-gravid. They had more than 6 pregnancies, more than 5 pregnancies, and these were about 248 mothers. So on the results component, we found that antenatal ultrasound utilization stood at 56.4%. That means about 211 mothers of the total that we enrolled used the antenatal ultrasound scan. They had 85.3 had about 1 to 3 scans, and 73.5% considered that the scan was affordable. They were able to do these scans from within. And even those ones who still chose to go and do outside for convenience purpose because of waiting time, they still said the cost was what? Affordable. 92.9% received partner support. We got to realize that most of the mothers who were able to do scans, they were supported by the husband that they could actually go on and do this. What did we find? What were the associated factors associated with increased utilization? We found that most of the mothers, the age at between 20 to 30, used ultrasound. We were beginning to think that maybe it is because these mothers, most times it is their first pregnancy between 20 to 30. And then those ones who were above 40 used utilized ultrasound more, because most of the outside interactions we're having was that they were told that when you clock 35, there are too many congenital anomalies and you will have to do a scan to keep getting to see what it is. Then we also found that the multi-gravida used a lot, because whenever they come to the ultrasound for antenatal, they will be encouraged to keep doing ultrasound. And the previous pregnancies gives them experience to do this, and they utilize it more. Then the grand multi-gravida as well. We found reduced utilization in rural residents. You find that these people who are coming from the village, most of them had not done any ultrasound, or even if they were referred, they were always referred just because there were complications already. So in what we got to realize that utilization in Gulu Regional Referral Hospital is much greater in this actually sub-region relating into Gulu Regional Referral is higher than the national estimate, which stood at 30, but below the ideal. So rural inequities remain. That means in the rural setting, many people were not able to get ultrasound. Yeah. So another thing is that increased utilization always came from experience from the pregnancy, from the previous pregnancies. We realized that those who had who got pregnant the first time and they had an ultrasound, and then they saw maybe no harm with it, the next subsequent pregnancies, they were able to always get an ultrasound scan. So in conclusion, we can go on. Yeah. So 6 in 10 women utilize antenatal ultrasound scan. The age, gravidity, and residence, urban vis-a-vis rural, significant influence utilization. And there is need to improve equitable access both in the urban setting and in the rural setting. So what did we recommend? We recommended that maybe they should decentralize point of care ultrasound to rural facilities, especially health center 3s. If we could get midwives trained in point of care ultrasound, many mothers would be able to benefit from it. Then strengthen ANC health education. Yesterday we saw Dr. Pebalo presenting a model where a midwife is able to report and then be able to do health education as she is also doing another work in case she's overwhelmed. Then increased trained ultrasound personnel. It's almost the same, talking about training midwives in point of care ultrasound. And then we need to really conduct multi-center studies across Northern Uganda to come up with a conclusive statement that Northern Uganda stands at this in terms of antenatal ultrasound utilization. So thank you so much to the participants who participated in this study. Gulu Regional Referral Hospital, Gulu University, our supervisors, Dr. Bomah, Dr. Ope, and my co-authors. I thank you so much for listening to me.
Thank you very much, Dr. Byron, for that wonderful presentation. Members, I'm guiding that we will take questions after all the presenters are done, and we'll prepare for just one burning question for each member. I don't know whether that's in order, but thank you very much. So I'll go on to invite Christine Nanunji. She comes up. Christine Nanunji is a young researcher, currently a medical student in the evening of MCHB. And she has more than, I think, 2 or 3 publications, plus others in the queue. And she's also an Eco Health Placement Awardee in the areas of social determinants of health. Thank you very much. Christine, the floor is yours.
All right.
Thank you so much, Dr. Bomah, Stephen, for that. Once again, I'm Gulu Christine. I'm in my third year from Gulu University. I think we are going to wait a bit as the project. But I'm going to talk about a study we did. It was an academic study. We actually recently defended it with my colleagues. It was about suboptimal blood pressure controls among the hypertensive diabetic comorbid patients at Gulu Regional Referral Hospital and St. Mary's Hospital. So I felt it wise to disseminate the results to such a conference, which is for Gulu Regional Referral Hospital. And we did it with a big team, and it was supervised by Dr. Felix Bomah, my mentor. Yes. All right, thank you. So this is yeah. So we investigated suboptimal blood pressure control among adults with diabetes mellitus and hypertension in Northern Uganda, and it was a hospital-based study. It was a big team supervised by Agent Dr. Felix Bomah. So we defined hypertension as a systolic blood pressure of more than 140, more or equal to 140 milliliters mercury, and diastolic of more than or equal to 90. The diabetes mellitus, a fasting blood glucose of 7.0, or an RPS of 11.1, or an HbA1c of more than 6.5%. And hypertension comorbidities, diabetes mellitus was a concurrent presence of both hypertension and diabetic mellitus in the same individual at the same time. Suboptimal blood pressure, which was our outcome, it was a systolic blood pressure of more than 140 and a diastolic of more than 90 at the study visit. So to talk about a few about hypertension and diabetes, globally, I think we can go to the next slide. Yeah, so globally, approximately 1.4 billion people aged 30 to 70 years were affected by hypertension. That was in 2024. And BM is associated with a 2 to 4-fold increased risk of hypertension, peripheral disease, and myocardial infection. This is why we chose people with both diabetes and hypertension, because more likely people with diabetes will have hypertension at the same time. And Africa accounts for approximately 58% hypertensive cases among people with diabetes, which shows that it's a kind of higher burden. So being with diabetes and hypertension increases your risk of cardiovascular diseases, renal failure, stroke, and high mortality. And this eventually leads to a sudden death, increased sudden death rates as a result of poorly controlled blood pressures, which we aim to address with this study. Our main objective was to investigate the suboptimal blood pressure controls and associated factors among hypertension comorbid adults with diabetes mellitus. That was at Gulu Regional Referral Hospital and St. Mary's Hospital, Nacho. Specifically wanted to determine the prevalence of suboptimal blood pressure among these people and to assess the factors associated with the suboptimal blood pressure. So this was a hospital-based cross-sectional study that employed quantitative approach, and we conducted it between October 2024 to July 2025. We conducted it at 2 hospitals at the BM clinics of Gulu Regional Referral and St. Mary's Hospital, which are all in Northern Uganda. And our population were adults with both diabetes mellitus and hypertension. And we included all hypertension comorbid adults, diabetes mellitus, who provided us written informed consents, and we excluded people who were sick and couldn't answer our questions. We had our dependent variable was suboptimal blood pressure. That was the blood pressure equal or greater than 140/90, and the independent one were social demographic factors like age, sex, clinical factors like your renal blood sugar, medication, then dietary and behavioral factors like your salt intake, physical exercise, and the sample size was determined using a formula Kish-based, where we used the prevalence of 82.5 from that study, and a 10% non-response rate, which gave us 244 participants. And we purposely sampled these participants. During our data collection, we used the interview administered questionnaires, and every after the interview, the patient was requested to sit in a relaxed manner, and their blood pressures were taken twice at 10 minutes apart. Yeah, I repeat it from that study. Descriptive analysis, that is percentages, frequency, and median, were obtained for categorical data numerous. Then logistic regression analysis was done using data, and the p-value of less than 0.05 was determined statistically significant at bivariate level. We got approval from GRRH and also administrative clearance from both hospitals. Then the study was conducted according to the NEC's declarations. And our results, since we had 2 objectives, our main objective was to get the suboptimal. And our findings, we found out that 49.4% of the participants actually had uncontrolled blood pressures, and also a higher number, that is 59.1%, their blood sugars were also not controlled at the same time. For the associated factors, we found majorly 3 associated factors. Next slide. Yeah, 3 associated factors. That was education level, occupation, and fasting blood glucose. So in the education level, people who had no formal education, secondary school or primary school were more likely to have uncontrolled blood pressure compared to people who went to tertiary and above. Then in occupation, we only found one significant, so the government employees were 7 times more likely to have uncontrolled blood pressures. Yeah. For fasting blood sugars, people did not control, who had uncontrolled fasting blood glucose levels were about 2 times more likely to also have uncontrolled blood pressures. So just to discuss a little about our findings, so we found about half of the participants having uncontrolled blood pressure, and this was similar to a study in South Africa, which also found about 43%. Though higher percentages were found from South Ethiopia and Southwestern Uganda, our neighbor here, so they found much higher percentages than us. Yeah, maybe because of the study settings or the behaviors of different people. Then in factors, we found for education level, that's the next slide. Yeah, so for education level, we found participants with primary, secondary, and non-formal education being more likely to have uncontrolled blood pressure, and maybe this lower education is linked to reduced health issues and poor health seeking behavior. And it was also the same in a study from Ghana and Ethiopia, where lower education was associated with uncontrolled blood pressures. Then for government employees, they were more likely to have uncontrolled blood pressures. And we are thinking that maybe because of the stress, maybe the busy schedules, and less physical activity, because you can see most of them are always in cars. So maybe they don't get time to walk around. And it was also similar from a study from Addis Ababa in South Africa. They actually get it significant. And lastly, the poor glycemic control was found significant, and it was similar in a study from Northern Tanzania and Ghana. This is because of the variation in patient sensitization, both education and adherence to diabetic management plans. So our limitation, we had 2 major limitations, that is self-reported data, which could introduce recall bias, and also selection bias, which could potentially limit generalizability. But we tried at least did about hospital study to minimize this. In conclusion, we found about half of the participants having suboptimal BPs, and the significant factors were primary, secondary, and non-formal education, being a government employed, and then uncontrolled fasting blood glucose. And we recommend that focused hypertension and diabetic education program, majorly focusing on the high-risk groups, which we found associated. Maybe we focus on people with lower education attainment, any education program screening or anything. We focus on these high-risk groups because they were significant in our study. Thank you for listening.
Very much, Christine. That was a good presentation. Can she receive a more? Yeah, thank you very much once again. I want to call upon Susan Imwai. Susan Imwai is a midwife at the Gulu Regional Referral Hospital, currently working in the Gyne department. She holds a diploma in midwifery, and her major interests are currently in maternal child health and then quality improvement. She's also a member of the Nurses Midwife Association of Uganda. Yeah. Ladies and gentlemen, Susan.
Protocol observed, ladies and gentlemen. Good morning. I'm calling my Susan. The just started by working in Gulu Regional Referral. Imagine a mother coming in labor and her mode of delivery, that would be a cesarean section. The procedure is done. She is nursed in the hospital. The doctor comes and looks at the incision site. It is very clean. And they discharge this mother home. She goes back home smiling, happy. In a week or 2 weeks, she returns back in the hospital with the pus in the incision site. She's distressed, macheted, and then imagine what went wrong home. What happened at home? What predisposed this mother to get a surgical site infection? So I thought about it and said, let me also, as other people do researches, let me also try and do a research about this. What happens when they go back home and yet they're discharged when they're okay? So this brings us to the title, Factors Associated with Post-Discharge Surgical Site Infections Following Cesarean Section. It was a case study done at Gulu Regional Referral Hospital. Next. While Health Organization defines surgical site infection as an infection occurring within 30 days of operation that involves the skin, subcutaneous tissue, deep tissue, or organs like uterus, pelvic cavity, manipulated during the delivery. Surgical site infection is a significant postpartum complication after cesarean section. It is one of the contributors for high maternal and mortality rates. It results to prolonged hospital stay and increased health care costs. Recent studies report infection rates ranging from 12% to 16% across regional hospitals in Uganda, whereas in Northern Uganda, the prevalence ranges from 16 to 33%. This is a photo of subcutaneous tissue infection. And that one is a deep tissue infection. So the objectives, I came up with the objectives of identifying the factors associated with post-discharge surgical infection following cesarean section. And then the other is to identify the possible solution of post-discharge surgical site infection following cesarean section. So then my method was a qualitative study was carried out where the mothers were interviewed, observed, and focus group discussion held in an objective of identifying the possible cause of surgical site infection. So this one I could do, like when the mother comes with sepsis, I talk to her, interview what happened at home, her lifestyle at home, and then during the time of wound dressing, we engage them to talk in a group discussion so that they share experiences of what happens at home. Out of the 38 mothers that are examined from January to June 2026, most of them reported inadequate experience in wound management. So these mothers, once they're discharged home, they don't know how to take care of these wounds. Most of them use they pour hot water in the Renzori bottle and they rub around it. And then they tie these wounds and they don't clean them actually. From the time they are discharged, it is kept tight and water is not allowed to drop in it. And then they also reported in poor home hygiene. When I interviewed them, I asked them how often they wash their hands. They said they only wash their hands when they're eating, and how often they change their clothing in a day. So most of them take like 2 days.
without changing their clothes and also their bed linen. And then also inadequate nutrition. Some mothers after discharge, I don't know, they have meats which prevent them from eating other foods. So we had one who was depending on only soup and tea throughout. And she came back when she was too emaciated, and yet nutrition plays a part in wound healing. And then also lack of ambulation. Once they go home, since they're operated, they're not allowed to move anywhere. You're supposed to sit, they support you even to sleep, they support you to get up. So your work is just to sit and lie down, not moving anywhere. And then also inability to follow up health care for early intervention. Most of them, once they are discharged, that is the end. They don't come back to the hospital for review. That they can easily identify this, identify the factors. In conclusion, psychosite infection significantly prolongs hospitalization, increase the burden on facilities, and are often treatable if identified early. So my recommendation here, I know we are doing health education, but we need to strengthen it a little bit on wound care and proper hygiene. And this involves cleaning gently with water and soap and leaving it dry. And also putting on loose clothes. Now nowadays we have .com mothers. Once they deliver like this, they want to go back and put on their fit tight clothes. But at least with an operation, it's encouraged for them to put on loose clothes. And also washing their hands before and after touching the wounds. Also help them get them on identifying danger signs on the incision site, like redness, full odor discharge, wound separation, fever, and possibly return to the health facility as early as possible. Because in some cases, you receive when the maggots have already developed in these wounds. So imagine how long this mother took after that time. Also, we have to help educate them on diet. At least encourage them to consume foods rich in proteins, fiber, iron, and take a lot of fluids, as it helps in wound healing. Then ambulation, at least we should encourage them when they go home. They are not supposed to just sit. Let them move around at least 10 minutes, short, gentle walks. And this helps to increase blood flow and prevent blood clots. Thank you. Actually, during my study, I also found out that some mothers have myths on sepsis. I had like 2 mothers who reported that when they developed sepsis, they took a lot of milk. So when you take a lot of milk, this milk goes inside and transforms and becomes pus. So it was really interesting. Thank you so much.
Thank you very much, Susan. On that one, I also had one mother who told the husband that she's supposed to eat chicken from the day she's operated up to 3 months. So the husband called asking, "Doctor, is it true?" It was a hard one for me to answer. Yeah, but some of those myths and misconceptions are there, and others do actually predispose mothers to sepsis. We've seen certain mothers put newborn babies in very hot water just outside the delivery suites. Very hot water. It's a culture here in Gulu. A young baby who is less than a day old is put in very hot water. I'm like, okay, how does this work? So some of the babies are smeared with the cow dung, others are smeared with the blue band. And these people, I'm sure even the health workers know these practices. And some of them are left to go unchecked. Please, health workers. Yeah, thank you very much, Susan, for that wonderful presentation and for your insights and intentionality to try and actually take on research. We advise and encourage other health workers, midwives, to try and do simple quality improvement projects within your units. It's also research that is valid within the institutions. And for your information, it might actually not require research and ethics approval because it's quality improvement research in most of the instances. Yeah, thank you very much. Allow me welcome Urban Kihumuro, our next presenter. He's a public health professional with quite some experience in the area of HIV and TB care, and he's also an ardent community health advocate. Thank you very much.
Thank you so much. Protocol observed. I'm not Urban, I'm doing Robert, and I'm just presenting on behalf of Urban because we did it together. So our presentation is basically to appreciate the research and the work we have done. So I work with CEHAD, the Center for Health, Human Rights and Development, and we support TB contact tracing interventions within Acholi, and Urban works with GCRC, Joint Clinical Research Center. So one of the interventions that came on board by NTLP was to bring men on board in terms of increasing TB case detection within the cities. So as GCRC and CEHAD, we collaborated together and brought the funds together to bring back the initiative within the city. And so as the title, we are strengthening male engagement to improve tuberculosis case detection in Gulu City, a collaborative initiative by LPHS North and Southwest, then CEHAD and the Gulu City local government. So the authors, Kihumuro Urban, Deo, who is the M&E specialist at the GCRC, then George, IT specialist, and then myself, Robert Dung. I coordinate TB within Acholi region in the 6th district. Next. Next. So the background of our activity is that vaccine reports and studies being conducted, and globally, men aged 15 years and above comprised of 54% of people who developed TB in 2024. That's according to the WHO Global Tuberculosis Report. And compared to the 35% among women and the 11% among children. So in Uganda, tuberculosis still remains a public health challenge, with men still bearing a burden of the disease accounting to 66 to 75%. And the mortality outcomes are also worse among men, 50% in the negative individuals and 51% in the people living with HIV. That's the report in 2025 by WHO. So notably, the proportion of people who died after starting TB treatment was 45%, higher among men than women. So largely, the contributing factors to this percentage were delayed health-seeking behaviors among men, then high-risk occupations, harmful social norms, and limited access to male-friendly health services. In most cases, we realize that men seek health care a little bit late. As a word of nowadays, they say men are committed, but it's causing problems within our communities. So based on these factors, we said we can do something, and those factors which contribute to poor or late diagnosis, poor treatment outcomes, and sustainable transmission within households, workplaces, and communities. Hence, the need to deliberate and target males within our communities. Next. So our objective was majorly to improve tuberculosis detection among men through the use of male champions and integrated community TB screening services in Gulu City between January 2025 and 2026. So we are majorly relying on a mobile TB van, which is at Gulu Regional Referral. Next. So at the methodology at national level, we had stakeholders engagement, and it's through that engagement that we cascaded and had a district level micro planning with the city health team to basically identify and select these hotspots with high TB within the city and plan the implementation. So upon the district micro planning, we also held a parish level community dialogue headed by the chairman LOC1s to mobilize the areas that were selected that have high TB instances. And we started with 3 parishes within the city to sensitize the community and identify our male action groups or our male champions who are going to be advocating for males to seek help. Then we, after selecting the male representative who had an orientation with them, we invited the MOH team and CDLD team to orient them and take lead in exploration collective male behavior change and TB male role modeling. So our phase 2 was to engage with the referral team to allow us to use the mobile TB van, and we do community TB screening at the hotspots that we are selected. So we also did sample collection, packaging, and transportation to the lab for processing and reliable results to the participants on time. Since the mobile van has a gene expert machine in it, so whenever we're in the community, we run samples immediately and give results to the client. So our results, with the intervention, the proportion of men diagnosed with TB has consistently remained above 50% in Gulu City, and this is consistent with the national target of 60%. So the highest proportion were recorded in February and May 2026, when the efforts of the male champions were complemented by the deployment of mobile TB van. So in addition, the approach improved TB case detection in Gulu City from 52% to 83% of the annual NTLP target. So, but as of last week, we are at 89% as per our national NTLP target. Next. So when you look at, this is just a graph showing the months when the implementation started, and the blue indicate the number of cases notified in that particular month. Then the yellow indicates the number of males diagnosed in that particular month. So when you look at January, you see that 54% still were male in terms of cases that were identified. Then when we did the intervention in February, you see the shoot was high. So this simply means that when we do targeted community outreaches targeting males, we can still identify more males who have TB, hence improving the health of the community. Next. So our conclusion, as we move to eliminate TB among men, task shifting using peers and engaging community through dialogues are effective in finding and treating new cases. Other settings with similar changes may adopt this. So we realize when you use peers, because we are moving in ghettos and we use their ghetto presidents. Then we also have males who have cured from TB, who are experts. So we are relying on the ghetto presidents within the ghetto, then the expert clients who are really doing our mobilization, plus the chairman ones within the community. And when you go into there, we are really seeing good results and we are achieving the targets as per NGLP. Next. So our recommendation is this collaborative model demonstrates that engaging trained male champions through structured community platforms can significantly enhance TB case finding among men, therefore we recommend. Then scaling up the male action group approach in other high-burden districts, this has potential to increase TB notification, reduce delays in diagnosis, and contribute to achieving Uganda's national TB control. So the intervention is within the city, but we have realized it can work well. So other districts with this particular challenge, we want to put and inject in our money in those other districts that have busy centers, and we also take on the services in those particular districts. Thank you. So our acknowledgements are the City Health Office, SEHAT, GCRC, and Gulu Regional Referral, and then Ministry of Health. Thank you.
Thank you very much, Mr. You say the name is? Robert Lungu. Yes, standing in for Ab and Gulu there. Thank you very much for that presentation. Members, we have one colleague who is going to be presenting online. She's called Irene Omono. I don't know whether her presentation is ready.
It's online.
Is she ready? Should be coming up in a few. Irene Omono is a medical educator, so please listen to her. Thank you very much.
Yes. Good morning, everyone. Are you able to hear me well? So this is Irene Omono. May I confirm whether I am audible enough? Hello?
Yes. Yes, Irene, we can hear you.
Irene Omono. May I confirm whether I am audible enough? I would like to sincerely thank the organizers. May I confirm whether I am audible enough?
Yes, Irene, you're very audible. We're able to hear you out. You can go ahead and start on your presentation.
Someone is on.
Yes, Irene, you're very audible. We're able to hear you out. You can go ahead and start on your presentation.
I would like to thank the organizers of this conference. You've been working day and night to make sure that this comes to success. Distinguished guests and panelists at the panel, and then all ladies and gentlemen. Thank you very much. My name is Irene Omono, once again, a midwife working with Lamu District Local Government. And I have the privilege today to share with you my abstract entitled Operational Models of Care, which is responsive for maternal health. This is facility evidence-based contribution from the program supported by UNFPA. So with your permission, I will continue with my presentation. But kindly, I'm not seeing the slides. Are you people able to see the slides?
Give us 1 second.
Okay. Okay, as they work on it, allow me to continue. Ask your mind why I have chosen this topic. Pay program is being supported by UNFPA in our district, Lamu, and we really appreciate it so much because it is helping the adolescents and young people. Midwives are the forefront and they are the first point of care when it comes to providing reproductive health services. Why midwife-led this kind of activity? I said we are the if a mother needs postnatal care, the midwives are the forefront. Family planning, the midwives are the forefront. And then we, the midwives, we really give care which is accessible and then continuous. And this care is respectful. And then this care that we give to mothers are tailored according to their different unique needs. So the care that we give to the adolescents and the young people, they are really tailored toward them. You know, they have different needs, they are different unique needs. So we give the care according to their needs. This is why we have I don't know whether you're able to see the slides. Sorry. I know time is going. Allow me to continue. So when we see in the background, I would like us to imagine this midwife who is working in antenatal, how she handles the adolescent and young people. When we see in our community, about 25% of these young girls who are aged 15 to 19 have already started childbearing. We would put ourselves in a situation whereby a young girl has got pregnant from the home. And then in our community, this young girl who has got pregnant, how is she or how did she behave? And then the challenges that she faced. Let's just try to imagine the situation of our facilities and in our communities. These girls face a lot of challenges. As a setting, according to the facilities, it is not enough. Like, I mean, in our setting of ANC, you will see that this young girl is pregnant first time. Her mother-in-law might also be pregnant, and then her mother herself may also be pregnant. And this young girl is pregnant coming to the facility. How, put yourself in that situation. How will this girl appear to the facility? Stigma, a lot of stigma. And then rejection. So these girls need to be helped. So with the funding from UNFPA, it has really helped to strengthen the system health. And then through these midwife-led models of care, it is integrated and it is friendly in giving care. So midwife-led models of care, it integrates in adolescent-friendly services. And these services, we have antenatal care, and then postnatal care. We also have intrapartum care, like when a mother comes in, and then postnatal care. So this care is really supposed maternity care. In respectful maternity care, this is a package of care whereby hello?
Hello, your network is lagging a bit. Do you mind going back a bit?
Okay. Like you could remind me where exactly?
On that very slide, the last bullet, yes. Go ahead.
Okay, thank you. Thank you very much, and sorry for the network problem. Okay, I was like, with the funding from UNFPA, the Strengthening Adolescents and Young and Youth Program, which is being supported by UNFPA, it has supported health system strengthening, and it is through these midwife-led models. I was saying, why midwife-led models? It is because the care we give to these mothers is accessible, and this care is continuous. This care is also tailored to this individual need of the adolescent. So it has really helped. Midwife can access care. All these adolescents can access care. We are the first point of care as midwives. When a mother has come to facility and she has had maybe abortion, we are the first point of care. And when a pregnant adolescent comes to the facility, we are the first point of care. So it is very important that we as midwives give this care to this adolescent. And then this model is integrated. It gives adolescent-friendly services. And these services, I was talking about the postnatal care, family planning services, and even and when these mothers also come for post-abortion care, we give them. And then these interventions are focused on respectful maternity care. When we talk about respectful maternity care, this is a package of care whereby a mother receives a care which is dignified, a care which is respectful, and a mother receives care which provides privacy and confidentiality. And this care that we give to mothers according to respectful maternity care, it is self-centered or it is woman-centered. It caters for her individual or unique need. Next slide, please. And then not forgetting the referral of the referrals that we make. We encourage the VHTs, the community health workers, there is pregnancy mapping. So there is linkage between community and then the facility. And we have actually given them the danger signs and when to report to the facility, when to refer these mothers to facility. The aim of this SAY program in response to this, we know midwife-led service models is one of the approaches which is implemented, whereby it improves access, quality, and continuity of maternal health services. Next slide. In our methods, we have examined this by the maternal continuum of care. This includes ANC access, screening, and preventive interventions, which in hence give us the continuity of care. And this, after doing it, the analysis was also done, and it is giving the benchmarking to access the operational performance. Next slide. According to this method that we have done, we wanted to know midwife-led activities. So it was really focused on this model of care. I told you earlier on that these midwife-led models gives care which is accessible, care which is continuous, and then care which is tailored to the need of this individual adolescent. And this targeted review provides granular evidence of the government contribution, of the program contributions at the clinical level. being supported by the UNFPA. Next slide. In the results here, after doing all those what we have done, performance data from Madupeo Center 4 indicated high utilization of strong and diagnostic coverage. You see, ANC came up to 111.2%. So someone may be asking him or herself that, why have these people surpassed the national target? This is because of referrals in Madupeo Center 4 itself has 5 lower units that make referrals to. And then Madupe is also bordering Southern Sudan. We have mothers and clients who come in from the Southern Sudan. And then the neighboring district as Kitgum. We also receive clients and mothers from there. So bringing us to having this 111.2%. And then there is also high uptake, which is potentially driven by the catchment population and mobility. And then when we see ANC early initiation, like ANC first visit occurring in first trimester, like the strategies that has been made, it really helped because screening all mothers at all entry points and then going for community outreaches, this has made this to be like 75.6% occurring in first trimester, which is still low. But compared to others, no, it is okay. And then when we see here, I earlier on said that in the method, maternal continuum of care by screening, and then a continuum of care. So we are seeing here like anemia screening is at 96%. And then when we see the IPT uptake is a bit low, this is because of late coming for ANC or late booking for first ANC. By the time they come late and they don't reach maybe fourth visit, because by the time we expect that the mother, by the time she comes for fourth visit, she will actually be having the third dose of IPT. But because of this low uptake, it is bringing us down. Next slide. Another result, we shall see that the continuity of care indicators demonstrated moderate retention. That is ANC4, I have talked about it. And then only 32.6 completed the recommended ANC 8th visit. This is because they come late for first visit, and they can't finish the 8th visit. And then ultrasound scan access still remains limited. Madupe Center 4 has as a facility has the ultrasound machine, but someone to operate it is the challenge. So what has been made always make referrals. Then when mothers come back, this is when we write the results for these mothers. So it is actually very low compared to others. Yes. Next slide. So here in the recommendation, to strengthen adolescent-friendly services within the facility, what we have done, there is group ANC whereby the adolescent and young mothers come on a separate day so that they are attended to, and then they have their own different time for coming. The challenge may be now the staffing, but at least we have put that young girls 24 years below, they have their different days for attending ANC. And then we have also created a specific and dedicated times for these adolescents so that they can receive all the care and services they need without fear of stigma. And then ensure the availability of staff dedicated to attend to these adolescents always. When you are at the facility, there is a tendency of these adolescents coming, moving. If you are to take interest in them, you'll find that they really need some help. So a staff at least is always put to make sure that these attendants, I mean, these adolescents are attended to. Yes. So I would like to thank you so much for listening. I really apologize for the network problem. I would have done this physically, but due to an avoidable circumstance, I couldn't make it back to Gulu. I was there yesterday. So my acknowledgement goes to Lamoa District Local Government and then UNFPA, Gulu Regional Referral Hospital. They are always here to support us. Mary Stops Uganda, Ministry of Health, Naguru Teenage Center, District Health Officer Lamoa, I believe he's there in attendance. And then not forgetting UCMB, Elma, and then the health workers of Madupeo Center for. Thank you very much.
Very much. Mono, thank you very much. Mono, thank you very much for the presentation. Members, I think we're opening the discussion now for some questions. We're going to be taking one question per presenter. Thank you very much. So Irene, kindly stay online so that you can take your questions when they do. So the floor is open, please.
Thank you so much. My question straight away goes to the first presenter. In your recommendation, you gave out that.
Yes, so this one, where go, that lady.
Conducting ultrasound scan. I really look at this. You also realized yesterday the same concern. Midwives are overwhelmed, and that is the area of specialization. So possibly, I don't know how you would look at it, looking at instead recruiting sonographers, so that we need to look at that. I don't know whether I'm given a chance to give to the next also. Post cesarean section.
I think we'll take one from you. Yeah, thank you very much. Yes, you have a question here?
Okay, thank you for the opportunity. My question will go to the second presenter, the person who presented about I just wanted to inquire if there was any health education done to these people with a low education level and were having uncontrolled BP and sugar levels. Did you talk to them after finding that maybe their problem is having low knowledge on the dangers of these uncontrolled figures, or the education will be done later? Thank you.
Thank you very much. Yes, Professor has a question too.
Thank you very much. My question to Robert. I was excited when you talked about ghettos and ghetto presidents. So I wondered how you identified the ghettos and how you came to know who were the ghetto presidents.
Thank you. My question goes to she presented on cervical site infection and C-section. Yeah, in interviewing these mothers, did you look at the bracket of these mothers and characteristics such as the level of education and the socioeconomic status to determine what you find as well? Thank you.
I think we're remaining with one question to to Mono, isn't it? The question to Mono.
Thank you very much. This is a question to Sister Irene Omono from Madioke Health Center. We have seen that in regards to ultrasound scan, we had 30.1%. And as you continued explaining, we have come to realize from you that there is no sonographer at Madiope to provide the sonographic services. How were you in position to acquire the 30.1? And earlier on, we also heard that there is shortage in human resource and what have you. Thank you.
Those are very good questions. I think we'll begin with Susan, since she's online and internet might become a problem. No, not Susan, but Irene Omono, the last question. Irene, are you online?
Can I answer? Okay, thank you very much for this question. You realize that this is very low, and the ultrasound services, if indeed was done from the facility, we could be at more than 80%. But these are mothers whom we refer them to another facility. For instance, we have Padibel Center 4, and then some ultrasound services from Kitgum. And then there is one private facility, that is St. Peter and Paul, whereby the mothers always have these services from. So when they come for these ANC services, we give them what they give them. Okay. And then we tell them about ultrasound scan, the importance.
What are you looking for? Do you have whom are you looking for? Huh? What is the
I'm
name?
here.
We don't have any victim here now.
Hello?
The one we have in the ward. Here, we don't keep patients here for more than 24 hours. So the ward is the other side. The ward is the only victim I know in the ward is Crawford. Yes. Oba was the conductor.
Yes, Irene, are you there?
Yes, I am.
Yeah, kindly go ahead.
Thank you once again for this question. I was saying, I don't know whether you picked some of the explanation, but I was saying, if ultrasound services are really done right from our facility, Madiope Center 4, we could be at about 80% or more than 80%. But these mothers always come to our facility. Then we have other services of ultrasound, that is from Kitgum General Hospital or any other private clinic offering these services. And then there is also Padibel Center 4, where we refer mothers to, and then some private facility called St. Peter and Paul. So we refer these mothers always for ultrasound scan, and then we give them the importance why they're supposed to do this scan, and then later on we make sure that we tell them supposed to come back with the subsequent ANC visit. When you're coming back, please come with your results of the ultrasound. Then when they come with their results of ultrasound, we put it in the register. That is why you are seeing it is kind of low. And we are advocating for at least a sonographer at Madiope, so that we pick up from there. Thank you. The machine is there, but no one to operate it. We earlier on had someone trained on that, but she went back to school. So we are lagging behind. Thank you.
Yes, I was saying there's a new structure in the Ministry of Health that even at Health Center 3s and Health Center 4s, if we look at the rural setting, Health Center 3s, you'll find that the structure, the old structure is the one they're using, which is about 19 staff. The 19 staff include only 2 midwives, and in that structure, there is no provision for a what? For a sonographer at Health Center 3. And yet we want to achieve at the end of it. So what we are trying to suggest is something which is workable. I told you I've moved in doing health system strengthening in very many facilities, rural setting. I can give you a practical example that Amon is talking about in Madiope. I moved to Madiope and I found that Sister Safari, who was the midwife there, she just mentioned that she left because she went to school. She was trained on point of care ultrasound, and she was delivering very well because she does antenatal at the end. When she sees this one needs antenatal, she's able to schedule them for antenatal. Now, I would like to give you a practical example in Ajuma district where I have been there for a long time. Is that midwives have been trained in various health center 3s to do point of care, and with the implementing partners in specific health facilities which are high volume, especially those ones which are refugee facilities. There are about 4 health centers which are very high volume, and the numbers they see are almost equal to a health center 4. But you will find that it is all about the duty schedule that these midwives are able to put. They know that on a Wednesday, we have ultrasound. So mothers are in the community, they also know that if I am scheduled for an antenatal visit on a Wednesday, it seems the midwife wants to do for me an ultrasound scan. And this is very cheap and very feasible. In Acholi sub-region here, the recent RC project, IX, was able to train very many midwives on point of care ultrasound scan. And that has been very visible in trying to help shape the utilization, because you can plan your duty, just like Dr. Bebalo was putting that thing of health education and the rest. Sometimes in the health center 3s, people multitask. Even the clinical officer, the clinical officer has a role to play in maternal child health. He can come in on doing the what? The point of care ultrasound. The clinical officer can come in and also help. Yes, they have their roles, but at least if you plan well as a facility in charge, you can be able to plan duty and allocate these midwives to continue doing point of care ultrasound for this. The burden, what I've seen in health in rural settings, is that people come late for work. They will say, okay, now let's go for work at 10. And then they want to leave at what? At midday. Then they say the work is pressing. But if you stretch for long, I think this can be planned with very good planning. So to make something workable, I think recruitment of sonographers is not a feasible thing right now. Maybe in the near future. That's why we recommended what? Training the available midwives. Thank you so much.
Yeah, thank you very much, Dr. Byron. I think that's a sumptuous response. Maybe to add on, that we've also had midwives trained and given this extra knowledge on point of care ultrasound. Quite a number of them, by the way, like around 4 or 5 within the regional referral. Challenges we've had, okay, to begin with the positives, of course, they reduce the burden of mothers seated in the queues waiting at the radiology department. We are able to actually deliver point of care ultrasound for fetal weight, fetal orientation, and then also gestational age estimation right at the antenatal clinic, and that's a good thing. The challenge we've had with such an issue is that these nurses or midwives that have been trained in these special skills, again, are redeployed to other non-user departments. And that's a huge issue. So you find someone who has the skill is in the NICU. Someone who has the skill is now at accident and emergency. And we think that's a wastage of resource. And in some way, maybe the planners need to rethink such decisions when they're made. Thank you very much. So the next question went to Nanonji. Something about whether you actually gave feedback. Did you do dissemination of your results? And then also, did you actually make these recommendations actionable by giving feedback to the people that actually require it? When you found that maybe the health workers or government workers, people with low socioeconomic status had maybe poor blood pressure or those control. Did you actually give feedback? That was a question that came in from one of the people in the congregation.
All right, thank you, Doctor. All right, I would be honest enough. We haven't gone back to the 2 hospitals to disseminate, but we shall go there and do the necessary and educate and give them what we found and what we think can work out. We are in the process of disseminating. I think that's why I'm here today. And we shall also go to the 2 clinics, that is from Referral and Nacho. Thank you.
Yeah, thank you very much. I think also members would agree that I think we can take this as an avenue of dissemination too. And we also have actors here, heads of government workers, and they can take this information back, right? Yes. Another question came in for Robert. Something about the ghettos. Please take it on.
Yes, how I identify the ghettos that we had a district micro planning, and during the district micro planning, we identify hotspots. So after identifying hotspots, we work hand in hand with the facility teams to identify, alongside with the chairman health woman, to identify and select the ghettos within the hotspots that we have identified, and then we conduct a community dialogue. So it's through that dialogue that the males in the ghettos will say this can be our leader in terms of mobilizing us to never have an activity. So it's through the dialogue that we identify those presidents.
One last question for Susan. Was whether she brought in other characteristics like age bracket and other demographic characteristics in the aspect of your research.
Thank you so much for that question. Most of the mothers that interacted with were below 25 years old. On education, majority of them were not well educated, but we had others who were really well educated. Thank you.
Okay, thank you very much. Members, this marks the end of our presentations of the abstracts. Thank you very much for listening. Could you please give a round of applause to our presenters? Yeah, I think we've taken some time while seated. I would beg that we stand up and do some stretch. We have a volunteer to give us some simple exercise for members to stretch up. Yes, Herbert. As we stretch up, I wish also to take the opportunity to invite the President, the Association of Obstetricians and Gynecologists of Uganda, to give his keynote address. Thank you very much.
All right, thank you so much. Let us all rise. In case you're holding anything in your hand, make sure your hands are free. Give yourself some space. You can back away from your chair a little. Yes, this exercise works for all ages, so please be involved. Okay. All right, so we'll be writing numbers with our waist. Okay, that was already done. Oh, okay, so let us do this. Give me your right. Do this, do this, do this, do this, okay? Do this. So I want you to look at me, okay? And do what I'm commanding you to do, okay? It teaches you to pay attention by watching and listening. Are we together? So you don't necessarily have to touch the body part, but at least get close to pointing at it. When I say touch your nose, you touch your nose. When I say touch your ear, you touch your ear. When I say touch your mouth, you touch your mouth while looking at me. Are we together? Are we ready? All right, touch your nose, touch your ear, touch your nose, touch your mouth, touch your eye, touch your ear, touch your nose, touch your mouth, touch your ear, touch your nose, touch your ear, touch your eyes, touch your ear, touch your nose. Speed is increasing. Touch your mouth, touch your ear, touch your ear, touch your nose, touch your eye, touch your ear, touch your nose, touch your mouth, touch your ear, touch your mouth, touch your ear, touch your nose, touch your eye. Is that your eye? Touch your ear. We are getting to a close. A little bit faster now. All right. 1, 2, 3. Let's go. Touch your nose, touch your mouth, touch your ear, touch your nose, touch your eye, touch your mouth, touch your ear, touch your ear, touch your ear, touch your nose, touch your mouth, touch your ear, touch your nose, touch your mouth, touch your ear, touch your nose, touch your mouth. Let me try to recover from it. Touch your nose, touch your mouth, touch your ear, touch your nose, touch your eye, touch your ear, touch your mouth. Look at me. Touch your nose, touch your ear. Thank you all so much.
I close my eyes. Thank you very much. Yeah, Professor Rajawangu Rogers, the floor is yours. I hadn't noticed my teacher is also around, Professor Otington. Good to see you.
Thank you, Dr. Bomah. Yeah, RDC. I saw him, he was here. Yes, a senior executive consultant for Gulu Regional Referral Hospital, senior colleagues in the profession, health workers at different levels in service, researchers, and all the people laboring to improve women health. Good morning, good afternoon. Gives me great joy to be here. I would like to thank the organizers of this powerful conference for inviting us to join in. We had planned to come earlier, but there were some engagements and we only managed to join you this morning. Now we wish we had somehow managed to come early because the few hours we have been here have been very rich. The discussion has been so rich, and we wish we had not missed yesterday, but it was not within our power. I bring you greetings from the Association of Obstetricians and Gynecologists, which is the body that brings together all obstetricians and gynecologists in the country with the membership of over 500 senior and junior colleagues who come together to champion reproductive health in Uganda. It is a rich association because we have members that are spread out across the different disciplines. We have members in academia. You can see even in this region, we have very powerful members like Dr. Pebalo, who are here representing us and doing very good work. And even other medical schools. Some of them have taken on the top leadership of the institutions. The DBC Academic Affairs in Barara right now is our member. The Dean Faculty of Medicine at Makerere College of Health Sciences, the Dean Faculty of Medicine at Kampala International University. All those are our members. We have several members who are heading institutions, medical institutions at regional referral level and even national referral level. So our membership is spread across, and we are happy to represent them, to be that voice that speaks for women health in Uganda. I would like to thank the leadership of the hospital, senior executive consultant. Thank you very much for putting this together. I know we have collaborated, but I also know for sure that the hospital has carried the heavier load to organize this conference. Please clap for the leadership of the hospital. I'd like to thank the people who have spearheaded the organization, Dr. Pei and your team. This is very well organized. Thank you very much. Please clap for them. I have been involved in organizing a number of such conferences, and I know it's not easy to put together resources, to put together the program, and to have people. You can actually have a very serious program and people abscond, they do not come, but I'm happy to see that we have a good representation of the region in the room. That deserves a hand clap. So thank you for coming and joining us. I was thinking through the theme, which paraphrase has to do with how we can promote research to improve the quality of healthcare in the region. Specifically this region, but I know this applies to all the regions across the country. The northern region is special for several reasons, especially the fact that for a long time, the development of the region in the different aspects was delayed, not denied, but delayed, because after all the events that happened, the region has got back on its feet, and it is actually now growing much faster than the regions which were not previously affected. That deserves a hand clap, ladies and gentlemen. You know, in life, when you get problems, you can choose to keep lamenting and mourning over the problems, or you can ride on them and move forward faster. And that is what the different stakeholders in this region have done to see that now hospitals in this region can be the best performing. That is incredible. To hear that loads and loads of research are coming out of this region, and to see individual researchers and clinicians standing up and topping and leading the research agenda in the country is incredible. So thank you very much. Dr. Bongo, Dr. Pebalo, Dr. Pe, the leadership of the hospital, and everyone who is doing a good job to put this region not just on the map of Uganda, but in leadership in the different aspects. So getting back to research, I am a researcher myself. I work with Bomah University of Science and Technology and Gulu Regional Referral Hospital. When you're a clinician and a researcher, then you know that none of those components can survive or thrive alone. You need each of them fit into the other. When you are in clinical practice, you need research to inform your clinical practice, to give you evidence. I can do 100 cesarean sections, but if I have not introspectively looked at my outcomes and determined which method will give me better outcomes, then I'll keep doing the same thing over and over again and think that I am helping patients, yet in some ways I might be causing damage. Let me give you an example. I am a urogynecologist and fistula surgeon also. So we now know from research, and it is documented, the paper is there if you search. We know that majority of the fistulas we are getting now are not coming from obstructed labor, as we thought. Majority are iatrogenic. Iatrogenic means they're being caused by clinicians who injure the neighboring organs, especially the bladder during surgery. So if I know that from research, then I know that for sure to improve the outcomes in these mothers, then I have to run away from simply increasing the number of surgeons at health center force to now training them to perform cesarean section in the right way. And so that is how research is feeding into clinical practice. And of course, research benefits from clinical practice because you provide, the clinicians provide the platform, they provide the data to inform the research, for the researchers to assess and give us their findings. So I thank the organizers for choosing such an important field that was very well thought through. What can we do? We know our challenges. We know that we are still losing mothers. We are now at around 189. There are other sources that talk about 170 per 100,000 live births in terms of maternal deaths. But we are trying to get to 70 by 2030, according to the SDGs. How do we get there? Like I started by saying that when you have a problem, you can choose to mourn over the problem, or you can choose to work and do what you can. We know our challenges, some of them are systematic. Those of us in clinical practice, you know, there are some women who come and it is the system that failed them. This woman attended all antenatal care from her facility. But the day she's in labor, the facility admits her, hopes that she will have a normal delivery. And then at the time when they discover she's not able to get to a higher facility in time, or they get a complication and she's not able to get to a higher facility in time for them to manage that complication. And most times we know it is bleeding. I hate to lose the mother to hemorrhage in this day and era. We know that happens, and we can keep lamenting. I'm sorry if lamenting is a big word, but we can choose to be helped, or we can all in our capacities do something. What are you doing within your power? If you're at that facility, what are you doing to improve how mothers are being managed? If you're in academia, what are you doing to make sure that your students have the right skills to practice in the right way when they finish? If you are leading a facility, heading a facility, what are you doing to ensure that the clinicians have the necessary tools to do their work? Those are the questions we should be asking ourselves. In our place as the leadership of the gynecologists in Uganda, we are doing the little we can. We are doing advocacy with the ministry. We are engaging our members and doing continuous professional development. We are encouraging such engagements for disseminating research findings and many other things. What we have told ourselves is that maybe we will not suddenly increase the health budget, but there are those small things we can do within our power. My hope is that we will leave this place asking ourselves, what am I doing to make a difference? Going back to research as I finish. Research is important, but many times our research ends up on the shelf. We now have to be thinking, how can our research make a difference, make an impact in the life of a woman? If I find that this problem is resulting from this problem, who can I talk to make sure that my research makes a difference? Does the Ministry of Health know? Does the senior executive consultant know that in Gulu Regional Referral Hospital, there is a high rate of sepsis among mothers who have cesarean section? Does he know that this might be because some women do not receive antibiotics? So, Dr. Bongomin, Dr. Pebalo, Dr. Ope, as we do research, let us disseminate to the right stakeholders. AOGU is also working to promote that. We're engaging the ministry to listen to our members who bring research findings. It is long overdue for research to just end up in shelves. We want the research to cause impact. And my hope is that that will be the determination from all of us. Once again, I would like to thank you for organizing such a well organized conference. And I want to thank you again for inviting us to participate and to give some remarks. Thank you very much.
Thank you so much, Professor, and thank you so much for honoring our invitation. This really keeps us very excited and knowing that the team is ready to walk the journey with us and being the very first of this. We hope that we can continue to do better and better as we engage with other fraternities. Thank you so much once again, AOGU, for coming in to stand with us. So, dear colleagues, we are going to go into our next program. But before we do that, let us give a very, very deserving appreciation to the president of AOGU for the information that he has given us and the very insightful information. Thank you so much. So next on our agenda, we are going to have a presentation of We're going to have a panel discussion, which is going to be led by our very own chair, Dr. Ope Jimmy. So Doctor, you're most welcome. After this, then I think we shall also be visiting Olailong for salt again. So as he does that, let me check if the borders around and people can help us source for the salt. Thank you.
Thank you, MC, for taking us through the whole day today, and I'm grateful that we are having a very wonderful discussion. This is going to be one of the vibrant sessions we are going to have today as well. We appreciate all the presenters that have made it today, but also we thank our president of the Association of Social Gynecologists of Uganda and their colleague whom he came with, Dr. Rumba Charles, who is who at the same time for Uganda Medical Association. Let me take this pleasure to present the following panelists for this part of the panel discussion. We'll be having our host, the senior executive consultant who has been here and hosting this conference. On his behalf, we have standing for our senior executive consultant is the deputy director, the head of clinical services of Gulu Regional Referral Hospital, Dr. Ojara Morris. Please, you can take us front. The second panelist is our very own, standing in for our Lord Mayor, is the Deputy Mayor of Gulu City. Yes, Mr. Harry Geoffrey, please, may you take a seat in front as he's walking through. We also have the next panelist will be our Deputy Secretary General of Uganda Medical Association is here with us, Dr. Charles Erumba. He has vast experience, so I'd like to request him to go in front and join the colleague. We're also going to be having our president. I know he has spoken, that's why I'm calling him last. Our president of the Association of Obstetrics and Gynecologists of Uganda, Professor Kazabwango Rogers. You're most welcome, sir. He's also the consultant obstetrician and gynecologist who is working at Bomah Regional Referral Hospital. Yes, having had this team of experience and personnel, we are going to be handling the area of leadership in health. I know it is very interesting to all of you, so we're going to asking them some few sets of questions. And in no particular order, we'll start with the first panelist that I called in front to usher us in with these few questions. The very theme for this discussion, for this panelist, is how we can use the leadership to improve healthcare provision in our region, but also extended nationally. We have that presentation here by our regional vice statistician, showing us the indicators and how poorly and how well we are doing. And therefore, it is very important for us to understand what the hospital is focusing on as far as promoting research to strengthen the quality of clinical care and service provision in our region. And therefore, I will request that our head of clinical services could respond to this question. You're welcome, sir.
Thank you so much, moderator. Good afternoon, everyone. Yeah, I'm delighted to be here to answer a few sets of these questions. And looking at what he asked, what we are doing to promote research as the Regional Referral Hospital. I would like to first start by informing you that the Ministry of Health has directed, and it is therefore our mandate to formulate and carry on research as one of the big pillar in promoting and also developing the health service. So one thing that came in the previous financial year was for us to strengthen the research committee of our hospital. And directive that came was that we should have the composition of this committee. The chairperson should be a qualified person who is active in research and is not a member or a staff of the hospital. And we acted, and immediately we formulated that committee, which is the one responsible for organizing this very scientific conference. And Dr. Jimmy Ope is our chairperson. So that's one of the biggest steps we've taken. And upon that, this same committee is mandated to, number one, to promote research in the region. It is not just simply within the regional referral hospital, but promoting research in the region. And also, they are also mandated to organize trainings in research-related activities. For example, training staff in the research methods, data analysis, grant proposal writing, and so on. So this deliberately, the administration is going to support as it has started. The same committee is also mandated to perform mentorship in research-related areas. One other very important thing that has happened is that we were able to gazette money. In the past financial year, we had something small really to promote local research, interventional research within the hospital. Up to around 8 million, just for people who can do research within. Okay, and with this coming or this financial year, that actually is going to increase much more. So this deliberate effort of increasing funding so that you can have more people participate in research, local research, as well as researches that are regional. Similarly, we build partnership with the institutions that serve this region, for example, Gulu University and other NGOs around who in the same vein carry researches. One other thing that we have also implemented is improving our data capture. You know, without proper data, you cannot get any meaningful research. It has been a directive by the Ministry of Health that we shift or we transition from paperwork to electronic medical records. I can inform you that Gulu Regional Referral has been one of the hospitals that was the first to transition in the whole country from paper to total electronic. And though there are challenges, as has been mentioned, in completeness of data, so we believe that this bold step is in the right direction to also empower research development. We also supports different individuals in their publication and data dissemination. Almost every week, we have got a team from different NGOs as well as our mother ministry coming to either carry research or to disseminate information that is being adopted to improve health service in the region. So therefore, I believe that these few things that we have been able to do provided some direction, leadership that promote research in our region. Thank you very much.
Thank you very much. Can we give him a huge applause? Yes. So money is there. The staffs who are here, the people who are here, our head has already informed you money is there. Start preparing to get involved. Writing proposals, trying to make sure that you get involved in research. Because money is there. For us, we're going to just ensure that the money comes to you appropriately. Now, to our next panelist, who is our Deputy Secretary General of Uganda Medical Association. You are aware that the association provides critical role, especially in the issue of advocacy, and you realize that health system requires that there are people who champion. We have had a lot of presentations here, and these are coming from our professionals, but also our other stakeholders. What are the roles of Uganda Medical Association in strengthening government programs in healthcare?
Thank you, Dr. Peck, and thank you, colleagues, for attending this conference. UMA is Uganda Medical Association is a voluntary based membership association, brings doctors together in Uganda voluntarily. It was started in 1964. That's how old it is. And it has a big mission. First is advocacy for the welfare of its members. And the other is to ensure that citizens receive quality health care from its members. Now, definitely as a way of contributing to what you have asked, we advocate for quality training, recruitment and retention of health workers. You know about train, but for us our role is to advocate that our members are recruited, like someone mentioned, that most of the public health facilities, staffing levels are below 40%. And advocacy is not a one-day event, but we are there to advocate. The other is making sure that our members are up to date with the current information from the research churning out. We do CPD sessions. And if there are members here, you should know that, for example, Dr. Riba hosts CPD sessions on touchy issues for members to really come get abreast of this. And that is one of the ways in which we ensure professional standards and basics for our members, but also policy advocacy and budgeting, lobbying, through lobbying, Ministry of Finance, Ministry of Health, Ministry of Public Service, through supplementary budgets, increasing the budgets to the hospitals, salaries of our members, and from 2017, something good happened to our members. I know it's not enough, but that is part of our role. But also we have leading in public health and management of diseases, outbreaks. Our members are at the forefront in leading, giving technical guidance and support in both public health and in NGOs. And when we come together with a sound voice, we're able to contribute positively towards supporting government and international research in our area. Thank you.
Thank you. Thank you very much, our dear doctor. He is standing for all the doctors in this country, and that's what he's trying to tell us what we are doing as doctors. So you realize that other associations where doctors belong, they also belong to Uganda Medical Association. Thank you so much, doctor, for the responses you made. May we clap for him, please? Yes, healthcare functionality cannot happen without the leadership, without the political leadership. Here in Gulu City, we normally refer Gulu as being heaven. And I've been telling people, visit Gulu to experience heaven on earth. And this is the only place where we experience heaven on earth. And the leadership of Gulu City is here with us. The Lord Mayor is represented here by Deputy Lord Mayor. What could therefore be the roles of the city council in promoting healthcare delivery in our region? You realize that most of the people come here to get specialized healthcare services. So what could be the roles that you are going to play, or what you have been playing in just 2 minutes or 3 minutes? Thank you.
Thank you, moderator. Delegates to this conference. My name is Geoffrey Ali, the Deputy Mayor of Gulu City. I am not a medic, I'm not a researcher too. I'm a political leader. Gulu City is one of the 10 cities in this country. We have a total of 2 divisions with 32 parishes. It is a new city, it's about 6 years old. With a large area which is newly annexed to the city. It is largely, the annexed areas are largely rural. For us, the political leadership, we have a role, an oversight role, to ensure that there's good service delivery to our population in the area of health, education, engineering, community services, and so on. So our role is really oversight. And as Gulu City, we have a health department, which is headed by a medical officer. And we have a number of health units in our sub-counties. Health Center 2, Health Center 3, Health Center 4. And a number of them lab facilities. And we also have the personnel manning these units. We have mainly clinical officers, midwives, nurses. We also have in the department environmental health officers. And these units, some of them are far away from the town centers, the city center. Also in the city, we have quite a number of other private health care providers, private hospitals. And you know that we have St. Mary's Hospital at Shore and quite a number of other smaller medical units within the city. The population of the city lives, some of them live far away. So it is these health units under our care that provide the services that they require, that they can easily access, and it is nearer to them. What are some of these services? We have antenatal care, postnatal care, maternity care generally. We also have general diagnosis and treatment of patients who go there, health education, immunization services, and so on. These are provided near the population. Also, they also provide referrals for cases they cannot handle. Referrals to Gulu Regional Referral Hospital, to Lacho, and to the other health units within the town center. That is one. We also have within the villages a structure that helps to take care of emergencies. We have the village health team. In every cell, there's a village health team that takes care of first line response, maybe to malaria, diarrhea, and so on. When they fall sick, like in the night, the hospital may be far, so they rush to the village health committee, which is able to provide emergency first line treatment or the first aid, so that somebody gets some little relief and is able to access a proper medical unit later on. Within the city also, we have a committee that addresses emergencies. Like we have had, we still have Ebola, we have an Ebola committee at the city level, where the city mayor is a member, the RCC is a member, the city town clerk is a member, the in-charge medical health department is a member, and a few others. So we have that team that is doing commendable work. Also within the city council, we have a minister, one of the political leaders in charge of health, education, and community services. That minister has a role of overseeing what takes place within that directorate and provides recommendations and reports to the executive committee of the council. We also collaborate very closely. We have partnership with the other health service providers, health hospitals, and health units within the city. We collaborate with. They also report to us. We provide a lot of services to them: waste management, water and sanitation. So we have quite a lot of areas where we collaborate in. Another area I want to talk about is sensitization of the population on health matters, awareness creation. As a city council, we also do that. Apart from going to the villages and do sensitization, also on the radio, we create awareness on health matters. When you tune to the local radio FMs, you get quite a number of sensitization messages on the radio. Malaria awareness campaign, Ebola campaign, awareness creation. As a city council, we are heavily involved in that. My prayer is that let us keep the collaboration alive and active. We request Gulu Regional Referral Hospital to collaborate more closely with the city council. We also want to have a representative. Maybe one of the council members of Gulu City should sit there so that when the board is having deliberations, we get the issues and we are able to collaborate more closely with Gulu Regional Referral Hospital. I thank you all for listening.
Thank you very much. I think that can be made better. Thank you very much, Deputy Lord Mayor. Yes, as he was talking, we have been able to receive other delegates who join us. We also have the Senior Executive Consultant of Gulu Regional Referral Hospital. Among us here, please. Madam, may you rise to the position? Thank you for coming. I must inform the Deputy Lord Mayor that she has been with us here for long at Gulu Regional Referral Hospital. We are happy to see her back here and join us to discuss how we can still improve the health within the Atlantic sub-region and the greater nation, that is Uganda. We also have committees as delegates from Uganda Nurses and Midwives Union. We have Ambrose Ochan. Please may you stand up for recognition. Thank you for coming, for joining us today. We also have Tony Adonio. Thank you for coming from the union, the same union. These are all people who are serving this nation passionately to improve her healthcare. They are our partners in many ways. We also have a panelist, our dear president of the association. He has elaborated when he was giving keynote address here, but I would like to ask two questions in one. How would the AOGU, being an association, collaborate with regional health facilities and government to enhance sustainable healthcare system? Thank you, sir.
Thank you, Dr. Pei. Yes, I want to also mention that the senior executive consultant of Bali Regional Referral Hospital is our member. So, like I said in the address, we thrive on our membership. So even when it comes to research and causing improvements in clinical care, we depend on our members. So we equip them through the different engagements, and then we later find that they are deployed in different spheres where they cause influence. The other thing we do is to promote collaborations with partners. We partner a lot with the Ministry of Health, and the current mode of operations in some of the departments at the Ministry of Health is to involve the association in coordinating the implementation of projects. This is solving a problem where we previously had segmentation of implementation. So you find different implementing partners working on the same thing, but in segments. One is here, another is there. They all don't know what the other is doing. So for some of the departments like clinical services, they have invited us and said, help us with the coordination and memorandum of association being worked on, and we hope that is going to help to solve that problem. So our preoccupation now is to make sure that in addition to the research that our members do, there is movement from research to impact. So that is why we are having a lot of engagement with the ministry. There is a lot of research. As an association, we do some research on a few projects that we run, but we also know that many of our members are doing research. So we are challenging the ministry. How can this research be put into, how can the findings be used to change policy? And that is the level at which we are operating. We provide avenues for dissemination of these findings. We run a fairly big annual scientific conference. I would actually like to invite all of you to the one this year. It will be in Kampala, Mestil Hotel, on the 24th and 25th of September. If you can join us, we will be grateful. I want to use this opportunity to ask the leadership, hospital leadership, to support some of the members who who would wish to attend the conference. Sometimes there's a bit of financial constraints, but we found some facilities support the members. So that avenue helps people to disseminate their findings. The other thing that we do is to provide avenues for real-time feedback, again, in collaboration with the Ministry of Health. Look at the LMNS system. If you look at how it is operating in the different regions, it is being run by members of AOGU who are helping us there to make sure that there is timely feedback to clinicians and improvements are made in real time. So that is, again, what I was talking about, that it helps us to know where there are gaps and enforce change not so long after the gaps are identified. So those are some of the avenues, and we have told ourselves as an association that maybe there are bigger things we might only be able to do in the future, but the small things we can do, like continuous professional development, like being in touch with our members, we are doing them to make sure that every week that passes, there is an improvement that is happening in the space of maternal and child health.
Thank you very much, our dear President. Can we give him the huge applause? Thank you. Thank you for the wonderful declaration. We have one more to answer to these questions. Just 2 minutes. As you give your parting shot, but you would allow me to ask some of these few questions remaining to the panelists. We realized that yesterday we had so many partners here, and even today, and we love that we talked about that all this presentation will not yield a lot if we don't end up collaborating, because through collaboration, that's when we will be strengthened. To our senior executive consultant of Gulu Regional Referral Hospital, what strategies are you using to collaborate with partners in the region that will help the other members also see how they could do that to strengthen healthcare services?
Thank you very much, moderator. I'd like to inform you that we have got a number of partners. And these partners come in different forms. We have institutions, we have organizations, and we have other government leadership areas in the districts. To start with, the institutions, planning, we have got the university, in which we have a memorandum of understanding to be a center, like a teaching hospital. And this memorandum go ahead to actually give opportunities. Yesterday we've seen that one of the biggest mandate of the university is to create research, scientific research. And actually, as I speak, the university has an open door for staffs of the regional fund to use their rec, and in a similar way also, staffs of the Regional Referral Hospital can apply for grants in the same way as staffs or members of the university. So this kind of collaboration give a lot. Actually, it gives no limits.
to research. So that's one. You can also be aware that as an institution, we have open doors. And when you're a student, you've seen one of our students who has carried out research in our institution. We provide that platform. In a similar way, also, we have got our members who are actually appointed as supervisors of people or workers. This helps a lot in not only building our capacity as an institution, but also creating. Okay. We have got this service. For example, CT scan. There are many researchers. I'm just giving the CT scan as an example. But we have laboratories, we have so many other services, specialized services, where you can derive researchers from. And this is available. People should know that this, you can actually do research down that line. We also constantly engage our mother ministry, that is Ministry of Health. This is important so that we can align our research priorities with the national health priorities. You cannot also prioritize research, maybe in I don't know which example I should give. Maybe right now you can give research on we have got Ebola, for example, which is maybe an epidemic which has hit us. You cannot prioritize the research in something which is completely not aligned to something which is going to help with the national health priority. That's what I'm trying to say. So this it also helps us to use the research findings that we get to help inform the different things. Like, for example, the guidelines, the treatment guidelines. You have the Ugandan clinical guideline 2023. So when the research is done, it will be updated again. So there are many other guidelines that we have, which is only research that can improve. I'm very happy that actually in the area of that clinical guidelines, we have got staff from the Regional Referral Hospital who has been consulted, and they have actively participated in updating this guideline. There are many other guidelines that has been actually also updated with participation of Regional Referral Hospital. This same thing can inform policies, can inform how service delivery and also even funding, there's no care, how it's split and distributed. Partnering with the organizations. For example, right now we have got TIFA. You know very well that USAID has gone. And we have in place TIFA, which is providing funding mainly on the area of TB. But there are other things that they give us opportunity to use the funding for. And one of them is development. It is upon the leadership to now guide where priorities are. Okay? And one other thing that we also do have, or we have given an open door to, is the promoting data sharing and research networking. Recently, we have got team. I hope we are aware that the team working on development of feeds for the malnourished children. That big research is actually being aided by a number of staffs of the Gulu hospital. And I'm very happy about that. It's going to inform the whole nation on which ingredients can we add so that we can improve on these feeds. So I think these are some of the few things that we are able to do. Thank you.
Yeah, thank you very much. Applause for you, please. Thank you for providing us elaborate information about the different collaborations you have and how members here, delegates here can still utilize that opportunity for collaborating with the Gulu Regional Referral Hospital administration and the staffs. Now, we know that Uganda Medical Association is a body, as we said before, that here, all of us belong to it, most of us belong to it here. And so we also know that the members of the association strengthen research. How would you, as Uganda Medical Association, in 2 minutes, basically strengthen research at the regional level, like actually sub-region?
Thank you, Dr. Pell. That question. Uganda Medical Association works in branches. Specifically, we have 16 branches, and one of the most vibrant is Acholi branch, and has been one of the best performing branches. And the leaders are here to complete one of them. And this has really helped us to decentralize whatever we want to do, so that each region is able to develop local solutions for their local problems using evidence, and that's what I'm talking about. We're able to partner through those branches, able to partner with the institutions of learning region, for example, Gulu University. And we know universities, their mandate is to generate data which will change people's lives. Unfortunately, our members are in the driving seat, and we're having more collaboration, but also partnering with regional hospitals. Gulu Regional Referral Hospital hosted UMA branch activity a few months ago, and it was fantastic, the hospitality, and we learned a lot about the collaboration and what was going on, and there was presentation of data locally derived. So that's one of the other ways how we do that, but also building local research capacity. I must say that our chair of the branch, Acholi branch, Professor Kitara and Professor Idru have done a lot of work in nodding syndrome. I know you know. And in that way, they're able to work with younger researchers and mentoring them, collaborating with them, but also holding symposium and workshops to disseminate that information. But also we're able to secure funding through grants, which directly support our members to do that research, derive evidence, change policy, and also translate that data into action, and also through conferences like this. And what we're looking for is the synergy, collaboration, working together, and also use this chance to employ our members who are not yet good standing to join, make it strong, and advocate more for ourselves, do research, improve our local situation. Thank you very much.
Thank you for that effort you are doing. I can ensure that the members are also engaged in research, which is very important for all of us. And we look forward to collaborating with you as a regional structure, but also as a hospital hosting this conference. Will be much willing. And we appreciate that you acknowledge that genuinely Acholi branch won several times accolades as the best Bomah branch in this country, Uganda. And we hosted a conference here. Bomah conference was hosted after the first Bomah conference to be hosted in any area outside Kampala. It was hosted here in this very
elephant hall where we are seated here today. So we are really privileged and we're so happy for that. But nonetheless, we have the final question that I would like to pose to our panelists, our dear Deputy Lord Mayor. You realize that we have been having emergencies. The emergencies we have been having are basically medical emergencies. Recently, we had an outbreak of Ebola, and all of us, we were on our toes. The first front line people to get Ebola definitely will be us, the healthcare providers, because the patients come to us first. So if there are people to die first, it will be the healthcare providers. The Lord Mayor, with the team, in the city council, will therefore be the last people at the tail. Having been affected a lot with emergencies, our dear Lord Mayor, what are the strategies that are there in place by the city council in this country to handle healthcare emergencies? Thank you.
Thank you very much, moderator. These emergencies, we have to prepare for them at our own level. In the city, we have disease surveillance and epidemic preparedness. We have the task force. And this task force is composed of political leaders. We also have the medical personnel in it. They get together and see how to address these emergencies which come. We also have the security is also part of the task force. And it is not the first time we're having the task force because of this Ebola. We had COVID. We also had Ebola much earlier on. In the early 2000s, we had Ebola. So this task force is reactivated and they are up to the task. The politicians, the task force is not in the hospitals. They are not in the isolation units. So those in the isolation units are our medical people, and they also report to us. Our role is policy. And sometimes when policies are made, policies can also translate into improved working conditions for the medical staff. There's a role that we play, and we work together so that we are protecting not only the population, but also the medical people that handle the emergencies which come. So we want to appreciate them for working closely with us. I don't know whether I answered that question.
Yes, you did answer very well. Thank you so much for the response, for the answers. Ladies and gentlemen, I am not going to ask another round of questions. I would like to thank our panelists for the wonderful responses you have given. We hope that this has kept us on our toes and will be used to help us transform healthcare in our region. Can we give them a huge applause as they go back to their seats? Thank you very much. Thank you very much, gentlemen. Unfortunately, the ladies were not there among them, but we hope equity can still prevail. Thank you very much. I would like to hand over to the MCs.
Thank you so much, Dr. Jimmy Ope. Thank you so much for the collaborative engagement that you've had with our senior managers and the teams that we are able to have with us. Once again, thank you. So colleagues, our time is actually much spent and our lunch we have been informed that our lunch is actually also ready. The salt that we have been looking for from Olailo, don't be worried. If it is not at your taste, we have something packed already for us. So Olailonga Boda has actually come back. So at this juncture, we're going to welcome a word of prayer to bless our lunch, and then we shall move out for our lunch. Today we are going to have our lunch at the mango tree when we slope down, slightly opposite where we had our lunch yesterday. And before you move out, let us ensure that you get a microphone just at the registration desk as you're stepping out. So at this moment, I want to welcome one of our midwives who has been very passionate for all these 2 days to attend the conference to bless for us the lunch. Sister Regina. Thank you.
You can raise up. Let's have us example prayer. Our God, Lord, save me in this day. Thank you for the gift of life. Most wonderful for the gift of provision. Call upon you this moment. Bless and sanctify the food before us as we partake of it through Christ our Lord.
Thank you so much. Wish everyone a good appetite. We're going to have 1 hour for our lunch and we get back in the room for our final part of the discussions. Thank you.
No, I'm not. Anglican. Is it full? No, I'm plugging. Discuss and come up with.
Sorry, let me that's no.
So our colleagues, we just want to remind all of us that as we go for our lunch, let us not have lunch and disappear. We still have very important programs going to continue. We still have a session of abstract presentation from our members, and we're going to have an award ceremony that is going to be very interesting for all the participants. So you never know, you walk away and you miss your golden gift. You're not sure that you've been the best attentive person and you walk away with your gift for being the most attentive person in the house. So let us not disappear. Thank you.
Ready for training?
Yeah, I told the question. You think the pot is yours. The saucepan is maybe.
It gives all the
Then when it comes to drivers, most of the time, it's a challenge. Give us the next year,
Yes. And the details are there, the details
Yeah, and you know, the president, at the end of the day, it's
No, some of the program because people in just one very long.
I will guess you may have found
It should
just like this.
So what? You don't have them.
No, you'll find out now. And there's no, not what was on. To select. The white one. Not the gun.
Hello. Hello. Hello.
What's the name you mean?
How many do you have for? You spent for the
Yes, I really must have any CD.
I spent. Then drive. There's no way.
Elementitis, elephantiasis, something.
But people yeah. I think. Thank you very much. Our question was what from it. So I forget.
Yeah.
I out a little. Could you just send me, maybe, is your number, this number on WhatsApp? I might not, I have picked the one for police, eh? I have picked the one, the information the police gave. I can send you on WhatsApp. That's the system, I need to get from the system. I need to extract from the system. Well, I'll get, let me just come to the hospital, I'll get from the IT team.
Mohammed Fafen juga. Ada brand. Hah? Awal keluar ya apa? Awal keluar ya apa? Wamero gene no mati kan no gene mati sampai tinggi lagi jumlah. Ini sih nggak biaya banget. Ini kan gue. Banyak. Mana banyak kan Francis Jordan. 9,000. We don't. For me personally, I don't know. I thought maybe you're aware of them.
We don't get actually. For me, they were sending me some whatever. I just do not respond to them. Yeah. I just get processed. Maybe what we do? Our aim is yes. You get them thing.
You know, kind of there, not very well. How is it you on you know, the one is better. You don't get near that can be better at the mafia. You don't know what you want to get on. Yeah, definitely better reflected. But we are those I think we want it of the paper trail. No,
if you get them out,
paperless.
Okay.
And I think the hello? Hello? Hey, what kind of you doing? Don't do I don't know very okay. So, I can what is your
So, in the Islam, when you what is the what is the what will happen because you're because that is what it is about it. Either one from the height, okay, not to violate bleeding, bleeding like that. Then they are testing it now to see whether okay. Then recommendations. For instance,
usually the assessment is what? Then the other one, the background is what happens.
What happened? What is the story behind the presentation? Situation is it presenting only what is the problem? So we are going for forensic. Okay. Then disinfection done, did it done? Yes. Okay. The time for disinfection. That's Time of arrival on the session. Yeah.
I wanted to very fast pick my phone. I go and do some.
Then I submit. So that means that means you will only submit after you're done with everything. If this is an amendment, it's come back. Okay? So next once we use the classification, besides location, now they are seeing doing it. Approximate, allow while using this time, allow this time, never allow. So you can get like when you're reporting it while you're and like now. And allow this time. So then people that block by location in the system. Yeah. So that is how we have thought. So what I need to do is it. Yeah.
These are the people which you are doing. I mean, from private or from Farah, and then give them another speak. Okay, thank you so much.
Hi, Rina. Sorry. This is Gulu region. The key team are still reaching me that they haven't.
Yeah. You know, you know. Okay. So they say I should launch this hyperextension on. Yep.
Hello.
We were invited.
Okay.
But they consulted us before.
Okay.
Doesn't seem to be responding. The next presentation. That's what is on
I don't know why it is big, but it was
So, yeah, I was told